All right. Okay. Assalamu alaikum, everyone. My name is Dr. MARIAM AHMAD. I am part of AMWPA. They have brought to you this program. It is American Muslim Women's Physician Association. I have Dr. YASMN Khan with me. Just to give you a brief overview of what AMWPA is, it's an organization of Muslim women's consisting of physicians, dentists, and medical dental students. Our vision is to just promote health in the Muslim community and in general with promoting health, welfare, and education of women. We do a lot of great opportunities, volunteer opportunities throughout the community. If you have any questions or how to sign up, please reach out to me at the end of the program, and inshallah, I will fill you in on how to become a member, inshallah. So without further ado, let me give you a brief introduction of Dr. YASMN Khan. She is a board-certified OBGYN who has been in the private practice in the DFW Richardson area for more than 20 years. She graduated from Aligarh Muslim University in Aligarh, India. She completed her OBGYN residency in NY Medical College, in New York. And she makes it a priority for promoting women's health and education. So Dr. YASMN Khan, I'll take it over to you. You will begin with just a few verses of the Quran, and inshallah, then we'll start our program. And also I want to say, if you have any questions throughout the program, please either post them in the chat, or you can, we will have a special time for questions at the very end, inshallah. Okay.
Assalamu alaikum, everyone. This is a wonderful forum, and I'm looking forward to a very nice talk. And again, if you have any questions or clarifications, please feel free to ask at the end of the talk. The talk today is oral health and its unique perspectives in the pregnant woman. And we're going to start with a recitation of the Quran. This is a Surah Alaq, which is, I think, very pertinent to us and this forum because it's all about education. So, Bismillah ar-Rahman ar-Rahim. Iqra bi-ismi rabbika allazi khalaq. Khalaq al-insan min alaq. Iqra wa rabbakul akram. Allazi allamal bil qalam. Allamal insan ma alam ya alam. This surah is especially very close to me because I graduated from Aligarh Muslim University, and the logo and the insignia of Aligarh Muslim University is Ilm al Insan ma alam ya alam. I will just give you a brief translation. Bismillah ar-Rahman ar-Rahim. In the name of God, the mercy giving, the merciful. Read in the name of your Lord, who creates man from a clot. Read, for your Lord is most generous, who teaches by means of the pen, teaches man what he does not know. So we'll get started with our program. And the only requisition for participating in this program is that you should have brushed and flossed your teeth. So hopefully everyone did that today. What I want you to learn at the end of this program is that oral health in pregnancy is very important. It can, if not taken care of, adversely affect the growing fetus and baby, and that preconceptual counseling should include oral health and dental cleaning. So for our primary care physicians, people who take care of women of childbearing ages, our OB-GYNs, this is very important to include in your, when you counsel patients or see patients. Okay. The first slide is going to be projected, Mariam, if you could put that slide. Changes in oral anatomy and physiology in pregnancy, just to give you a perspective of why things can go wrong with oral health in pregnancy. It's generally due to the increasing levels of hormones, estrogen and progesterone. What estrogen does is it causes an overgrowth of the gum capillaries increases capillary permeability and angiogenesis. So what that does is it causes softening of the gums, hyperemia of the gums, and so gums can become hypertrophied and can also cause bleeding. The other hormone is progesterone, and for some reason this predisposes to plaque-causing bacteria and gingivitis. Also, another condition in pregnancy is vomiting in pregnancy and hyperemesis, which is because of the circulating hormone levels, the beta-HCG. And so gastric reflux can occur. This causes acid to come in contact with dental enamel and can cause erosion, overgrowth of bacteria, plaques, etc. There are some salivary changes in pH that happen during pregnancy. There are increasing levels of estrogen, protein, sodium, and all this can be a milieu for overgrowth of bacteria. The next slide is an overview of some of the oral conditions that can occur in pregnancy. At the end of the talk, we will project some pictures, and I will hand it over to Mariam to go over a little bit about maybe the anatomy of the teeth and the gums and the various conditions that can occur. But basically, there is a misconception that pregnancy can increase periodontal disease. That is not the case. It is because there may be pre-existing plaque and there may be a neglect of the oral cavity during pregnancy, and that can cause increased periodontal disease, which is basically disease of the gums. There's hypertrophy of the gums, as I mentioned, called gingivitis. There's a condition called like a granuloma, pyogenic granuloma, which is, again, overgrowth of the gums, and this can be in 1 to 5% of people. And sometimes it might, if it's very painful, it might need to be lasered off or excised. Dental caries and tooth mobility can happen because of the changes in the gums and the mechanism that helps teeth anchor to the gums. And again, all this is because of the delayed gastric emptying, causing increased acidity, increased bacterial growth, increased angiogenesis, which is outlined in the slide. Moving on to how periodontal disease can adversely affect the pregnancy. So we do know that there can be carcinogenic bacteria that can grow in the teeth. These bacteria can cause an inflammatory response. This is by sending bacterial toxins, endotoxins, and release of cytokines, etc., through the placenta, causing inflammation of the amniotic sac called chorioamnionitis, which is a known entity for preterm labor, can also decrease the blood flow to the baby, cause growth retardation. On the slide, you can see that periodontitis can affect about 30% of women of childbearing age, and that periodontal disease has been identified in up to 12 to 18% of preterm births. This is a great morbidity to the growing fetus. It also is a lot of health dollars that is spent in taking care of premature babies in the NICU. So if dental and oral hygiene can positively impact that rate, I think that is a win-win situation. And so I really thank Dr. Rehana for putting this together, and Mariam, and all the great dentists out there. Next, we're going to talk a little bit about how to prevent problems and how to take care of periodontal disease. So what intervention can you tell your patients to do, and what can one do? Regular brushing and flossing, a soft brush to decrease plaque buildup and bleeding and irritation of the gums. There's a picture of xylitol, which is an antibacterial. So xylitol gum, mouthwashes, chlorhexidine mouthwashes can keep the mouth clean. And then something important, sodium bicarb mouthwashes does help decrease the acidity after vomiting. So you can have your patients do mouth rinses with that. Fluoride-based toothpaste, and then of course decrease in sugary foods and drinks, and early intervention, dental cleaning, and the pre-pregnancy oral exam would be an important part of this to help patients get preconceptual cleaning. The next slide is a little projection about intervention in each trimester of pregnancy and what is advisable in terms of oral health. So in the first trimester, which is 0 to 12 weeks, the obstetrician can talk about oral health and the changes that occur in pregnancy and how to manage it. People do get very distressed about bleeding gums in pregnancy or hypertrophied gums, and we can tell them and reassure them that's normal and how to take care of it with the soft brush, etc. So educate strict oral hygiene, plaque control, and then in this time, we would like to limit dental prophylaxis to only emergency treatments. So if you do need a dental cleaning, it's good to do it after the first trimester, but if something is very important and is an emergency, it can be taken care of. Also avoid routine x-rays in pregnancy. The other thing that you don't want to have dental issues or dental work done in the first trimester is that 1 in 5 pregnancies will end in a spontaneous AB in the first trimester, 0 to 12 weeks. And if they've had a dental cleaning, then they might have some confusion as to if that caused the miscarriage. And so something, just a practical tip for our dental friends to think of. The next slide, please interrupt me or let me know if I'm going too fast or if anything is not clear. If you can't hear me, just raise your hand or send me a message. The second trimester is between 13 to 27 weeks. The good thing is organogenesis is complete. It's safe to perform oral dental procedures. And we do give a dental letter to our dental colleagues, which says, about the safety if they ever need anything in that regard. Oral hygiene instructions, plaque control. So scaling, polishing, and curettage may be performed if they're necessary. Control any active oral disease. So if you need antibiotics. Okay, I'll just briefly give you an overview of the second trimester. The take-home message is that it is to do any dental cleaning, radiographs with appropriate lead shield, any disease has to be addressed and procedures to be done, scaling, polishing, curettage, and again, avoid unnecessary x-rays, but if it needs to be done, they can be done. And this is a safe trimester. So now we come to the third trimester. Remember now the third trimester, the abdomen is much larger, the fetus is larger, so there are some certain considerations to be taken care of. Number one, the oral hygiene and instructions and plaque control remain the same. You can again do the scaling, polishing, curettage if necessary. You could avoid it after 34 to 36 weeks, that would be good. You can do x-rays on the lecture. At this time, the patient is somewhat uncomfortable. So the few things that need to be taken into consideration is the dental chair positioning. Towards the end, I have a slide which shows you that venous return can be impeded by the growing uterus. So you should have the patient in the left decubitus. So, if she's more lying on, displace the uterus from the intensive blood. Supine tension, and you can avoid that bleeding time. And also, if you can limit interventions to before 34 weeks, as I mentioned, but elective procedures can be done. And we can go to the next slide. Any questions about that? So the next slide is just under local anesthesia, and FDA category B is approved for the normal lidocaine, prilocaine. We do like to avoid epinephrine. That makes it a category C. And okay. I think I'm having some issue. Is this better?
We can hear you, and we're starting to see you again. Like you're moving.
Can you hear me?
Yes.
Can you hear me now?
Yes. Perfect.
Yes.
Yes.
Okay, great. Sorry about that. So we were talking about guidelines and precautions during dental procedures. Local anesthetics may be used without a problem, and lidocaine and xylocaine is category B. If we could use it without epinephrine, that is preferred to prevent increased blood pressure, especially in the third trimester. Sedatives like benzodiazepine, Versed are to be avoided, and also Ativan. Nitrous oxide is not rated yet by the FDA, and so its use in pregnancy is currently controversial. And if you remember from your OB-GYN days, nitrous oxide is the twilight anesthesia, which can relax the uterus and helps in pain control. So we probably want to avoid it during the third trimester in a dental office. Antibiotics in pregnancy can be used very safely, and amoxicillin-based like Augmentin are all category B, Keflex, penicillin-based antibiotics. If somebody is allergic to penicillin, you can use clindamycin or erythromycin, but not the estolate base, because that causes some cholestasis. So your regular erythromycin is fine. The next slide, please. So pain management, oral pain management is acceptable. You can use acetaminophen, Tylenol. Ibuprofen is okay in the first and second trimesters, and we'd like to avoid it after 28 weeks because it can delay closure of the ductus arteriosus and affect cardiac physiology in the newborn. So Motrin is to be avoided after 28 weeks. Tylenol is safe, and Motrin is okay before 28 weeks. I think I put 26 weeks, which is fine. Percocet, oxycodone, hydrocodone are category B in the first and second trimester. It can be avoided, but it still can be used if necessary in the third trimester for pain control. But it should be avoided because it can cause a little withdrawal symptoms in the baby. The next slide, please. Just a little consideration about X-rays in dental procedures. Number one, it is important to limit it to anything that is necessary. And if it is going to impact the way the dental work is approached, then yes, please go ahead. But otherwise, if it isn't necessary, you can avoid it. Limit X-ray exposure to the second and third trimester, definitely not in the first if possible. Always use a lead shield because, and a properly collimated beam and high-speed film, which decreases fetal exposure. Scatter can occur to the abdomen from maxillary and anterior posterior views. Something very important is to know when the patient's last menstrual period was. If it's a woman of childbearing age and she's come to you early in pregnancy, always make sure that she is not pregnant if you are doing a dental procedure. So the critical period of fetal development is 4 to 18 weeks after conception, and fetal exposure to radiation should not exceed more than 0.2 gray, because that can cause microcephaly and mental retardation. And just to give you a little perspective, background radiation occurs every day to all of us, about 3 millisieverts per year. And you can look up the various units of radiation, but basically all of us are exposed to about 3 millisieverts per year from natural cosmic rays, background radiation, radon in the house, and things like that. A dental X-ray is very safe, and it only increases your exposure to radiation from natural background radiation to 1 day. So whatever radiation you're getting every day, if you do a normal dental X-ray, it'll only increase it by 1 day, a panoramic X-ray by 3 days, and a cone beam CT by 22 days. as opposed to that, I'd like to bring some perspective to this. A CT of the abdomen and pelvis can increase your radiation equivalent to 5.1 years. So just something if somebody would like to know about that. The last slide is about dental positioning that we had briefly touched before. And this is a lovely slide that Mariam has found. Again, we discussed that the inferior vena cava, postural hypertension, and so have the head up and left decubitus, if possible, for positioning of the pregnant woman. Just to address, I think somebody had asked a question about whether pregnancy can be a little more carriogenic. And it is true that progesterone can increase predisposition to plaque bacteria. And estrogen actually causes some desquamation of cells. And these cells become a good nutrient for bacterial growth. And so that could be a reason why you can have more caries. And so oral health is important. I can let Mariam take the field now because we are projecting some pictures. This is a pyogenic granuloma overgrowth of the gums, which can be painful. Sometimes may need to be excised, but generally it will go away, resolve after pregnancy. So it looks odd, but it'll resolve after pregnancy. And hypertrophy of the gums and stuff. So gum disease in terms to know. Okay. There's gingivitis, inflammation of the gums, periodontitis, inflammation. I don't know if Mariam, would you like to take over?
Yes, I'll go ahead and do that then. Just for our non-dental folks that are on here, kind of just to fill y'all in the differences in these terms. Gingivitis just means you have inflammation of the gums. You know, if you're not taking care of your teeth, your hygiene, you're not flossing, and you notice your gums are bleeding, chances are you have gingivitis. This is to differentiate between periodontitis, gingivitis. You do not have any bone loss. Once you have all the other categories in gingivitis, characteristics of gingivitis, and you also have bone loss, then you have what we call periodontitis. And subgingival calculus is just basically that tartar buildup, that plaque that has gotten hard over time. If you have that underneath your gums and it's a lot of it, then you could have periodontitis. And then the progression of cavities, it starts off with what we call decalcification of the enamel. So what we see in teeth, like the white, yellow part of the teeth, that's the enamel. So it starts with decalcification. Then once it gets bigger, you start to see the browning. It starts to get sticky. It starts within the enamel, and then it carries on to the second layer, and that's dentin. When that starts to get sensitive, that's when it's gotten a bit bigger. And then finally, the last stage is if it gets into the pulp, usually requires a root canal at this point. Sometimes it carries well into the root. You start to develop an abscess, an infection. Depending on how severe the infection is or the cavity, how big it is, you can either try to save it with a root canal and crown, or it will need to be extracted. Usually in this stage, you can get by with the filling. Sometimes in this stage, the white spot, you can just monitor it, have them use fluoride paste to kind of stop the progression of it. And so that's that. Going back to periodontitis, this is what healthy gums and teeth look like. And on the x-ray, you don't see any bone loss. Gingivitis is when it gets a bit to be inflamed, especially around the gums, the teeth here. You'll start to see kind of red spots. They start to bleed. Still no bone loss if you compare the x-rays. But starting around this part, all the way up to this part, you start to see some bone loss. It's hard to see in this x-ray, but you'll start to see these little flicks of calculus or tartar buildup building in there. Sometimes if you go to a dental office, they'll call out numbers as they poke your gums. 3 or less is good, but once you get to 4, 5s or above that, that usually means you're starting to get periodontitis. So a prophy basically is a general cleaning, little bit of scaling. That's generally for our healthy to our gingivitis patients. We give that. But for a deep cleaning, where we have to do a lot more scaling, we reserve that for our patients who have periodontitis, you know, who have some bone loss, who need extra deeper cleaning than your regular superficial prophy cleaning. And I hope that kind of clears up the confusion between a deep cleaning and a regular cleaning. So I will stop the screen share and let me, do we have any questions, concerns for Dr. Yasmin to clarify? Let me see in the chat, no one posted, okay. I'll open it up to Dr. Yasmin for questions.
I think there was one question about bacterial overgrowth in pregnancy. I don't know if the original caller wanted to re-ask her question or if she's satisfied that I answered it. That maybe
did you want it to
pregnancy can cause increased predisposition to.
No, I think you did answer it. I believe you just addressed the question right now, like a little while ago. Thank you.
Okay, thank you.
Any other questions, concerns? Don't be shy.
So, okay, so somebody said that mostly dental offices have 2% lidocaine. 2% lidocaine is fine. If it is free of epinephrine, that would be good. And again, if you do need to use epinephrine, it's fine. Generally, I think all dental offices do take the patient's blood pressure. And if there's any concern, always just put a phone call through to the obstetrician. And also in an earlier discussion with Dr. Rehana, who is an anesthesiologist, she was talking about if you need to do Versed or sedation, then yes, it would be good, number one, to talk with the obstetrician to see if there's any contraindication, and number two, probably to do it in a hospital setting, because you really don't want to give any of these narcotics in which there could be some issue with aspiration. The woman is pregnant already, so you don't want to do it in a dental office. But yes, if you need to do dental extractions, root canals, I think that they can be done under local anesthesia, if I'm right. Right, Mariam? Most of these are done with lidocaine. So. Did that answer the question? That lidocaine?
I believe so. So basically, yes, she said yes, thank you. All right, any last minute questions did anyone have for us?
So just to let you know, root canal is fine in pregnancy, deep cleaning, superficial, prophylactic cleaning, all that is fine. There's a question, would medical clearance be necessary for a dental procedure? Yes, I do think that a letter from the obstetrician would be pretty standard of care. to satisfy the dentist that everything is fine with the pregnancy. Most babies and mothers are very resilient. You really can't hurt anything, but good to avoid, the NSAIDs, non-steroidal anti-inflammatories, Motrin, in the third trimester, and avoid benzodiazepines and things like that.
Perfect.
So hopefully that was a useful talk for our colleagues, and kind of tells us what to look out for with oral health and pregnancy.
And
Ma'am,
I think we'll,
I have a question for you.
yes.
How do we know? Some of the dentists, they tell you, oh, you need a deep cleaning. How do we know that they're telling the right thing for you? Sometimes they just want to charge people more. I mean, I'm just nothing against dentists, but I mean, sometimes they do, whether really deep cleaning. How do we are sure that they're telling you the right suggestion?
Yeah, and unfortunately, there are some dentists that take advantage of, patients like that. I would generally kind of look at your habits. I mean, if you have a lot of buildup on your teeth, like, your teeth are really rough, you have a lot of tartar, chances are you're going to need a deep cleaning. If you look at the x-rays, and we're kind of trained to look at that ourselves. If you see a lot of kind of bone going away from your tooth, meaning there's some bone loss, like I'll have to pull up the PowerPoint for you, but if you look on the x-ray, you'll see the levels of bone loss as it progresses. That will indicate you need a deep cleaning. A lot of times they call out numbers, and again, you can't really trust those numbers because they could be skewing it. It's just unfortunate, but if there's calling out numbers more than 4, that means 4 millimeters of the pocket depth between like the top of the tooth and the bottom of your gum. So if there's calling out numbers more than 4, then generally speaking, you will need a deep cleaning.
So how many 4 numbers you need to have before you have a deep cleaning?
You need at least 3 or more, if I'm not mistaken, throughout each section. So this is a quad. A quad consists of, I want to say, more of like for example, between 8 teeth. So 8 teeth, and then there's 3 numbers, there's 6 numbers associated with 1 tooth. So you need to have at least 3, 4 millimeters or more of like 4 millimeters or more in each quadrant, 3 times to indicate deep cleaning. It's very confusing, but yes, that's basically what.
Well, if you're doing cleaning every 6 months, then I don't think you really need deep cleaning that frequently, do you?
No, you don't. So this is more for those people who haven't seen a dentist in several years. Then they will need to have the deep cleaning, and then they will need what we call a maintenance cleaning every 3 months, just to prevent any more bone loss.
Got it.
What is the difference? What is the difference between a deep cleaning and a prophylactic cleaning? What is the procedure?
So that was going back to the last slide in the picture. If you have healthy gums or you have gingivitis, you just basically need a superficial level of cleaning that is just focusing on the top of the teeth. You don't need any deep cleaning that will go underneath the gums. If you have periodontal disease where you have lost bone, then you need a deep cleaning.
I think there was a question.
Yeah, she's just adding to it. Sometimes patients can't see tartar and can still have perio disease. You can always have a second opinion to make a diagnosis correct. I agree. Second opinions are much needed always in any healthcare department.
True.
All right. Well, I will go ahead and end the program from here. I want to just say thank you very, very much, Dr. YASMN, for dedicating your time and for pulling those slides together. I really appreciate it. I appreciate AMWPA and Dr. Rehana for arranging this platform for us to allow us to learn from each other. And inshallah, I look forward to more discussions. And to my dental team here, if you have any other questions related to the medical field, or if you are interested in a topic, feel free to shoot me a message and I'll get together with AMWPA to arrange more talks in the future. Okay.
Great. And if anyone has any questions afterwards, they're happy to reach out to me if there are any pregnant related oral questions.
Last thing, we do have our YouTube channel for all these discussions. This lecture will also be on our YouTube page, inshallah.
Wonderful.
All right. Well, thank you.
And then-
Jazakallah khair. And have a
Jazakallah.
good
Thank
Sunday,
you.
inshallah. Assalamu
Thank
alaikum.
you. Bye, everyone.
Assalamu
Take
alaikum.
care.